Suppose a patient is having hypertension and we have to optimize the oral antihypertensive in the ICU. How should we select the oral antihypertensive? Somebody may come to you and say, add minipressexel. Somebody will come to you and say, add arcamin. Another person will say, add eprisol. What is the correct way? How to decide what to do? Let us discuss. So obviously, when we are giving oral antihypertensive, that means it's a non-emergency situation, right? Because in emergency situation, always the preferable agent will be an parenteral or IV agent, right? So in a non-emergency situation, when the BP is high, I want all of you to remember the backbone of a antihypertensive medication. It starts with calcium channel blocker. Always, if patient is not getting anything, start with calcium channel blocker. That can be amlodipine, cilnidipine, right? Because virtually this drug has rarely any contraindication in the ICU except for heart blocks and florid heart failure. This is the first drug that you want to add to a patient who is having blood pressure high. The next step is in the ICU, always assess for two things. Number one is if the patient is having AKI, if the patient is having potassium that is too high, or there is in the ICU there is frequent volume shifts. We are giving fluid sometimes, we are removing fluid, patient is on fluid restriction, removing from septic shock, all these things. So if it is there, then AC inhibitor or ARB cannot be given. If patient has no AKI, GFR is okay, potassium is okay, then the logical next step of antihypertensive choice, the BP is still high on amlodipine, is ACE inhibitor or ARB. You can give a telmisartan. Usually we give telmisartan. This is number two drugs. This is number one, number two. And these two forms the backbone of antihypertensive medications in the ICU. So a patient who is having hypertension, first you should add calcium channel blocker. Second you should add a telmisartan. If after all these things BP is still high, BP is still increased. Now what to do? Here I want all of you to segregate the patient into basically two phenotypes, phenotype 1 and phenotype 2. Phenotype 1 means patient is having volume overload, can be CKD, can be heart failure, and phenotype 2 is patient who is having ischemic heart disease or coronary heart disease, who is having tachycardia or controlled heart failure. All this is a phenotype 2. There is another phenotype, is phenotype 3, that can encompass all these two phenotypes, that is can happen in this, can happen in this, is called autonomic dysfunction. And autonomic dysfunction has a specific cause in the ICU that you have to find out. For example, patient can have pain, can have hypoxia. Basically dysfunction means here, because BP is high, there is catecholamine excess, autonomic hypersensitivity, autonomic hyperactivity. So pain can cause, hypoxia can cause, increased CO2 can cause, delirium can cause. It's basically sympathetic overdrive. In ICU, especially we see it in resolving septic shock, when the vasoplasia is getting converted to a normal vascular caliber. If your patient is volume overloaded, JVP is high, there is pedal edema, there is sacral edema, there is crepes in the lungs, ascites, effusion. So you have to find out. Then here BP is still high despite amlodipine, telmisartan. Here you add diuretics, especially Lasix loop diuretic. Then, as I have discussed in the previous class, you can add on a PCT blocker like Diamox. You can add on a DCT blocker like a Metalogen or Gitanix, or a collecting ductile blocker like Panlactam. If the patient is having phenotype 2, that is tachycardia predominant and ischemic heart disease and coronary heart disease, here you add beta blocker, cardioselective beta blocker like carvedilol, bisoprolol, etc. Now you can see a heart failure patient can be having volume overload. So at that time the patient is both phenotype 1 and 2. So you have to add both Lasix and beta blocker. Of course, in acute setting, you avoid beta blocker, you give one Lasix, And once patient is stabilized, you add beta blocker, right? So if patient is phenotype T autonomic dysfunction, here you treat the cause. If despite treating the cause, patient has a basal sympathetic overdrive, here you can add a sympatholytic, and that is clonidine or arcamin. You can see it is coming 1, 2, 3, 4, and this is the fifth drug. Sometimes you use the arcamin like the number one drug. No, this is a wrong approach. The correct approach is calcium channel blocker. If telmisartan can be given, should be given. If patient is volume overload, Lasix. If patient is ischemic heart disease with tachycardia predominant, beta blocker. Both phenotype, first control heart failure, volume overload, respiratory failure with Lasix, then add beta blocker. The sympathetic overdrive, autonomic chaos like resolving septic shock. There sympatholytic can be used, Arcamin, but this is only breeze. Never use Arcamin is a definitive agent because rebound hypertension is very high. Plus, it can sedate the patient. So your assessment of the ICU patient will be compromised, right? So after this also, if patient still remains hypertensive, BP still high, this is called a resistant hypertension. We are given at least 3 drugs, still BP is high, resistant hypertension. Here I will suggest you add pyronolactone. Obviously potassium is normal. This is the rescue drug for a resistant hypertension. Then comes the role of prazosin or aprosol, hydralazine. And very last, you have given everything, still if it is not controlled, you add these things. I have made specifically this video because sometimes I see people start from the below. They add prazosin, they add aprosol, they add arcamin. This is a wrong approach. First, you should always, the backbone should be a calcium channel blocker and a SE inhibitor. Now you can ask the question, if I am giving amlodipine before going to telmisartan, why not increase the dose? Let's say for example, I have started amlodipine. BP is 180 by 100. I have given amlodipine 5 milligram and BP still 180 by 100. Now what to do? We have two options. Either increase amlodipine to 10 milligram or add telmisartan, right? And it is always better to add another agent than to increase the dose of amlodipine, because the rationale is the first dose that you are giving, it has bigger effect. Subsequent increase in dose, smaller gain. For example, if Stamlo 10 milligram causing a delta SBP of 10 millimeter Hg, Stamlo 15 mg will cause delta SBP of only 12. So the difference is only 2 millimeter Hg. But here if I add telmisartan, then delta SBP will be 10 millimeter Hg. Remember, for every drug that you have written here, at usual dose, it should decrease the systolic blood pressure by 10 millimeter of Hg. So the difference is here is 20 millimeter of Hg. So you can see if I add another agent, then the fall in blood pressure or control of blood pressure is better. So always add second agent, and then if BP still high, you want to add third agent. This after this third agent, when patient is on triple antihypertensive and still BP is high, then you optimize the drug dosage, right? This is very important to remember. Patient is on amlodipine, BP 180 by 100, amlodipine 5 milligram, SVP still high. What to do? Do not increase the amlodipine. Add another agent. If BP still high, add another agent. After 3 agents, if BP still high, then optimize the dosages, right? This you have to remember while following this chart. And another advantage of this system is you are not increasing the dose of a particular drug, so toxicity will be less and effect will be more. So always follow this protocol. So this discussion will be incomplete if you do not say about the emergency situation. So in the emergency situation, when BP is high, so this is called hypertensive emergency. Patient is having SOB, heart failure, altered mental status, chest pain, or aortic dissection, or ICH, or acute ischemic stroke, neuro ICU. All these patients, they need IV antihypertensive. Never rely on oral antihypertensive there. No matter how stable the patient is. Always use labetalol in the male neuro ICU or labetalol plus GTN in every other places. Labetalol in NICU and in aortic dissection. And you can use GTN in other places, especially in ischemic heart disease, ADHF, plus you can use Lasix IV infusion or bolus. So this is a fact that you have to follow. And this lecture will also be incomplete if I do not say you that whether the BP you have measured, which is high, is it true or not. Patient may be having a smaller cough, just check it. There can be pain that is not handled. There can be hypoxia that is not handled. There can be fever that is not handled. There can be hypercapnia. Bladder may be full. Patient may be restrained. Patient may be having withdrawal symptoms from alcohol, drugs, cigarette, everything. So all these things we have to see. These are the reversible cause of hypertension. If these things are not there, it's not an emergency situation, then follow this protocol. Thank you very much. I'll see you in my next class.